Welcome to Detours Understanding Acquired Brain Injury. And with us, we have Blake, as you recognize him. He's our uh, resident expert on CTE, and he's as you know, he's a survivor like the rest of us. And so we're going to be talking about traumatic encephalopathic syndrome, or TES, which is basically CTE as diagnosed in a living person. And we'll be talking about each of the specific criteria. Um, in this, it's not necessarily a new kind of diagnosis, but it is finally an agreement between neurologists in order to allow a physician to make the diagnosis. And we'll be talking about um, each one of these criteria that you have to meet in order to receive a probable, possible, or an unlikely diagnosis of TES and how it connects with CTE. We'll be putting the diagnosis up here in the video so you can kind of follow along with us, okay? So, Blake,
Nice.
introduce yourself.
Hey, everybody. My name is Blake Walker. I got my CTE diagnosis actually just in June, early June. I was fairly surprised that they actually gave me the diagnosis, but yeah, it's good to see that they're making progress, at least trying to find ways to give people diagnosis to help them.
For a long time, unfortunately, there's been a lot of debate. Some say it looks like this, like that. And for over 100 years, we've known that basically it all starts with repetitive MTBI, repetitive mild traumatic brain injury, and
Yep.
it's you see the symptoms, but it's like, what exactly is it all about? And now we're starting to admit, it's like, yeah, hitting your head a bunch of times isn't good for it. I mean,
Right.
duh, but still,
It's taken us a long time. Yeah.
diagnosing it and recognizing what it is what this is all about. And so we'll just start. I have a list here of the official general criteria for traumatic encephalopathic syndrome, and on the list, will which is we're posting right here. All right,
Yeah.
first of all, you need a history of, as you can see in the gray box under number one, the general category for TES. All four criteria must be met. As you can see, they're numbered. And so the first one is you need a history of repetitive head injury. Now, please note, this doesn't mean you need to be knocked unconscious. A lot of people seem confused by the idea that you got to be like knocked all the way out. No, not true.
Right.
Just repeat head injuries. So blows to the head. And, there's a question as to how significant of a hit. Um, Concussion definitely would be one of those kind of blows, but a good like shaking or a car accident where you got shook up pretty good.
Nice whiplash. Yeah.
Exactly. And so we're also going to consider with the definition of MTBI where you're confused, or for even just a minute or two where you're really like, I don't know where I am, or I've got questions, what's going on, or I maybe have trouble with my memory, where I have a persistent headache after a blow to the head. That's an important potential criteria for the kind of thing. It's like I'm nauseous, maybe I threw up after my head got shaken up, that
Right.
kind of thing. These are all potentials. And even if you didn't go to the ED or if they released you immediately, that doesn't mean you didn't sustain a mild traumatic brain injury. Remember, your skull is not a helmet. All right.
Right.
So, number one, history of repetitive head injury may or may not result in a traumatic brain injury. But at least one of these five criteria then must be met. One, at least four concussions, or there's the key word, or mild traumatic brain injuries. That's one of the
Hmm.
possibilities. It's so remember at least one of these five things. So at
Right.
least four concussions or mild TBIs, at least two moderate to severe TBIs. It's me. At least 6 years of organized contact sports.
Yep.
That would be you plus the MTBIs.
Yeah.
Military service or combat exposure, other significant repetitive head injuries. One of these five criteria, like domestic violence. So if you've
Yeah.
been a survivor of DV, and it doesn't say necessarily how long, Um, so because your chances are higher. So if you meet one of those, 5 criteria, any one of them, that is sufficient enough to flag the first one. So at least 4 concussions or mild TBIs, at least 4.
Yeah.
Or at least 2 moderate to severe TBIs, or at least 6 years of organized contact sports, or military service with combat exposure, or other
Right.
significant RHI. And that can come from all kinds of places, not just,
Explain
organized
explain RHI.
repetitive head injury.
Okay.
And talking
No, I
about
saw that on
mild
the I saw that on the list, and so I was like, wait, RHI.
repeated head injury,
I
repetitive head
hadn't seen
injury.
that acronym before. Go on.
So, like, if a couple of falls would count. Domestic violence would count. Equestrian sports. A friend who has actually a couple of friends who have that. Where you horse falls, that counts. That's also like athletic activities. But
Yeah.
domestic violence, motor vehicle accidents, that's all these kind of things repeat and either mild TBIs or severe. All right, next. 2, clinical core features. At least one of these must be present. And this is how it's grouped. It's grouped into cognitive or a mood based uh, conditions. So you can either have the more cognitive or the more mood based TES. So if it's more
Yeah.
cognitive based, at least, significant impairment in memory, orientation, language, um, attention focus, executive function, or visual spatial. So you'll have a deficit in, if you have the cognitive flavor, more
Yeah.
memory, orientation, use of language, like word finding, or you can't like put sentences together, stuff like that, or have trouble understanding with words, or stuff like that. Memory,
Yeah.
orientation is knowing where you are, getting lost in familiar places, things like that. The visual spatial function, putting things together, understanding relationships between objects, things like that. Executive function, that's like ADD or ADHD kind of symptoms,
Right.
judgment, organization, all that good
Not being
stuff.
able to complete start tasks, things like that.
Yeah, exactly. Stop, finish, apathy, like lack of self initiation, stuff we've talked about.
Yeah.
Um, let's see. Behavioral. This is another flavor. This is another one. Behavioral, described as explosive. So somebody who goes off like that. Short fuse, out of control, physically and or verbally aggressive. Cusses people out, or gets like, you know, or intermittent explosive disorder. Sometimes they may be calm and relaxed. Other times they may just, you know, so this is the behavioral mode. So if again, it's like at least one of these patterns is present, or mood, feeling overly sad, depressed, hopeless, or a diagnosis of major depressive disorder or persistent depressive disorder. And that is more on the mood side. So it's one of those 3 diagnoses for core clinical features. So do you have more of the behavioral, do you have more of the cognitive, or do you have more the mood variant and those
So
different groups of symptoms?
so for me, I personally I've got a kind of a mix of all of them.
Yeah, and
And I know there's a lot of people with CTE that there's a combination of all of it. And I think the tough part is that they kind of for me it'll trigger the next one,
right.
right? So my cognitive's going down, I'm getting confused, I'm
Mhm.
getting upset, and then then I
As
might
they, I think they want to make it
overreact about
clear,
something, or yeah.
as they said, at least one must be present, and I think this is to cover the initial stages when you're
Right.
progressing through it. But any one is sufficient. This
Right.
is
Catch
to
catch it earlier, catch it
catch
earlier
earlier,
in
and so if
somebody.
you have
Right.
even just one of these, and it's not the whole cluster, it's just one symptom within any one of these domains, means oops, this
Oh
is a
wow.
yellow flag. All right, then also supportive features. At least 2 of these must be present. A documented decline, delayed symptom onset after exposure. No, so it's not something that pops up immediately. That's more like regular old traumatic brain injury. So this is something that you
Right.
notice that documented decline at least 1 year, delayed symptom onset after exposure, and symptoms such as impulsivity, anxiety, apathy, paranoia, suicidality, headaches, motor impairment. So at least two of these, they pop up later because it is a progressive disorder. So you may
Right.
have had, symptoms of your traumatic brain injury, which is really what this is, mild TBI, but a progressive disorder. And as they said, at least 1 year, a documented decline, delayed symptom onset after exposure. So this isn't, like I said, something that pops up after your TBI. You notice these declines over time. And the
Right.
impulsivity, the anxiety, the apathy, the paranoia, the suicidality, the headaches, or the motor impairments. So that is what it takes. At least two of those supportive features. And finally, the clinical features must be present for a minimum of 12 months. So they must be hanging on. And then finally, the criteria for traumatic encephalopathic syndrome, the diagnostic subtypes and modifiers. So if you meet these, then they'll give you the what subtype of TES you have. And cognitive, as they said, the cognitive core features are present without the behavioral or mood problems and without functional impairment. So if it's primarily cognitive, then they would say you have a cognitive subtype of TES.
Okay.
If it's more behavioral and or mood features without the cognitive problems, then they would say you have TES, the behavioral or mood subtype. Then there's mixed, which is where you have features as you were talking about. So we would say, you have TES with mixed features. And then finally, there's dementia, which is the cognitive core features and functional impairment. So problems with activities of daily living, like taking care of, making food or like paying your bills and all this kind of stuff. And this is progressive where you're starting to, like have basic functional problems. Um, and then there's also another modifier, which is with motor features. So these are the diagnostic subtypes, and then motor features modifier, at least one must be present. So dysarthria, now dysarthria is trouble talking.
Mm.
And dysphagia, which is trouble swallowing.
Is that more of a mutism, or like
No,
your
that's like
actual your
slurring your words and
vocalizing?
yes,
Yeah. Okay. Okay.
trouble with slurring your words, trouble with, I mean, you've seen like
A
classic,
stutter.
yeah, classic
Yeah.
punchy
Sometimes I'll get into
mode, right?
I'll get into a drone monotone sometimes. I'm like, oh, what was that? Yeah.
Yeah, trouble putting sentences together. Arthria, meaning how you coordinate your lips, your tongue, and that's more about like the motor skills of assembling words. That's not about, that's about how you say stuff.
Okay.
Um, Dysgraphia, which is trouble with writing. Your writing
Oh,
is altered, how well you write, how clear it is, and it's change. That's also important to remember. It is like a progressive change. So you're getting worse with your writing. Bradykinesia, slow movements, difficulty moving, coordinating your movements. Uh,
that's a tough one. That's a tough one because, you know, years ago, I didn't. You don't. Normal people don't have to think about their movements, think about what
right.
they're doing. You just your brain just does it, and you just go about your day, your athletics, whatever you're doing. And there's a lot of times if I'm having a bad day, it's like I'm thinking about
Yes.
every like, oh, you're walking here, look out for
Mhm.
stuff. You go down the stairs, grab the handrail. Like
And
it's
that is part of what the bradykinesia is
yeah.
about. Also, tremor, rigidity, and gait change. So, I mean, tremor, I have tremor, but it's gotten worse over time. Um,
Yeah.
Rigidity, you're locked up. Basically, everything is like, and you have trouble
Yeah.
moving your body, your arms, your legs, your head. You have trouble moving it at all. And it's kind of a pseudo Parkinsonism.
Yeah, I feel like it's not that you can't move, but it's like your brain won't, you're just stuck in that spot. It's like this weird,
Right.
why haven't I moved for a half hour? What in the world, you
And that's
know?
also part of the apathy and adynamia, which is also
Oh
part
yeah.
of and symptoms of this too, as well as the rigidity and the Parkinsonism. And it has something to do with the imbalance between acetylcholine and dopamine. We're not going to get there at this
Right.
point, but it has to do with neurotransmission we're definitely not going to get into that right now.
Yeah.
Obviously, falls and a lot of the other like movement problems that you see in Parkinsonism. This is part of where the punch drunk idea comes from pugilastica dementia from so long
Hmm.
ago, because these Parkinson type symptoms, and why you've seen with a lot of well-known boxers, they have these movement problems. This is the pseudo Parkinsonism.
Yeah, I don't know why it made me think of this, but there's an old Evander Holyfield
Yes,
interview, and I just had to stop and go, there's no way he always spoke like this. And so I went back and looked at all these old videos of him as a young boxer, and just how different it is, and like just how people don't see that. Like it's just right in front of our face. And it was sad because he was actually interviewing to have another fight, and he was in his 50s, and I was like, oh, what are you doing? This is just.
and that's an example of the motor features. And here's the thing, it's not just in boxers, it's not just in football players. You see some of these things, depending on the nature of it, in survivors of domestic violence, child
Yeah.
abuse, as they get older, and it's mistaken for other things because physicians and, other medical professionals don't recognize. And this is only newly recognized by neurology, too. All right. And so it's often dismissed, and many people in nursing homes and other facilities have this, and it's mistaken for Parkinsonism,
Right.
Alzheimer's,
Yep.
frontotemporal dementia, and other dementias, when what you're actually seeing is this. And the problem is that the earlier kids start taking hits to the head, the more this pushes this disorder forward. And
Right.
as you see from the criteria above, it doesn't take many hits to the head. And it doesn't take severe ones either. Just a good knock is sufficient to start the cascade of progressive dementia. And it's possible, based on what we understand about childhood dementias, that some of these may trigger other neurological disorders in kids, developmental disorders, ADD, ADHD, oppositional defiant disorder. We don't know enough yet to
Or
say, but it's
maybe
possible.
not maybe not trigger them as much as like exposing them,
Well,
right? They
no,
don't have
but
the.
also cause. We don't know enough, but there are some theories.
Oh, right.
It's like it may well be that when that 8-year-old or 9-year-old's diagnosed as having learning disabilities, oppositional defiant disorder, whatever else, we may be seeing prodromal symptoms. We don't know enough yet, as I say in just about
Yeah.
every video, but it's been hypothesized. It's a speculation, but in the neuroscience community, we don't yet know enough. So for now, this is but there are
Yeah.
childhood disintegrative disorder, Rett syndrome, and a couple other conditions where we see children have childhood dementias
Hmm.
and just don't know. Genetics plays a role too. If you have genes for Alzheimer's or any of the other tauopathies, um,
Yeah.
that obviously exacerbates the circumstances as well. All right, and then finally, there's what's called the clinical course modifiers, which determines how, whether it's active or not in you at the moment. Because remember, this is a progressive disease over time, and unfortunately, it's invariably fatal. Um,
Right.
but there is stable history or tests indicate little, if any, change at the moment. So stable, progressive, clear indication of progression over 2 years. So that's obviously, where you see, so it's in 2-year blocks. Unknown or inconsistent. So you don't know whether either A, as a clinician, you're getting accurate information, or whether the disease is like moving and stops and starts, kind of like Alzheimer's or some of these other disorders.
Oh,
Again, there's
okay.
confusion. So, you may move forward with your symptoms, may get worse, and it may stop and start again. And there seem to be two blocks where you start to see this in age. Typically 30s, 20s, 30s, and around 60 to 65. And those are the two times where we see this start to cycle up and back. And then for chronic traumatic encephalopathy, this is where imaging is more of a thing, because that has its own implications, whether you know, where we go with this, I don't know.
Hmm.
That's because that's considered almost separately, but that has more to do with relying on imagery. And it goes like this. Progressive course for probable CTE. Um, at least one positive potential biomarker. Now, a biomarker is something, a change in the brain or in the body that can definitively be measured. Because we've relied on autopsies to this point for CTE, we still need
Right.
something that is you can put your hand on. The last stuff we talked about is TES, Traumatic Encephalopathic Syndrome, and that is what they're calling CTE in living people. That is while the disease is progressing. CTE is what we've talked about in the past. So at least one positive potential biomarker. First of all, positive PET scan looking at tau. Okay, the tau, the aberrant protein that you and I have discussed before. So positive PET using a tau marker. Here, this is what a positive PET scan looks like, right? With
Nice.
negative PET amyloid imaging, because amyloid's more associated with Alzheimer's disease. So you have to rule out the markers specifically for Alzheimer's. You need to rule in the tau marker, but the amyloid, that's got to be out.
Hmm.
So
Okay.
tau in, amyloid out. Okay. Um, Next, you need another option is the normal beta amyloid. Again, that's that amyloid associated with Alzheimer's in your cerebrospinal fluid. There are tests where they can literally, stick a needle in your spine, draw out small quantities of cerebrospinal fluid, look at that. And if you have normal beta amyloid in your CSF levels, then they know it's less likely to be something like Alzheimer's specifically, more likely to be CTE because they look similar, clinically speaking. But you would have an elevated CSF tau, p tau to tau ratio. And that's the measurement between the aberrant tau versus the kind you should have. Because remember, this condition is made of this defective protein, the tau proteins. Okay.
Right.
So also looking at cortical thinning, examining, putting you in an MRI machine and looking whether there's been brain tissue loss. I mean, that self-evident. So at least one of those
Yeah.
things must be positive, potential biomarker. Also, if PET tau imaging was performed, it's got to be uh, positive. It's got to be present. So if they were
Yeah.
looking for that's another neuroimaging marker does not account for clinical features. So don't let other imaging say, nope, you don't have it. So even if they do a SPECT scan or CT and whatever, you still can, if the PET scan is affirmative, you still can then say as a clinician, yes, this person
Yeah.
has, if the PET tau imaging was positive. Okay. Next, for possible CTE, they may not meet the criteria for probable, which is based on PET imaging or based on CSF examination. Um, it's progressive and they have the symptoms, well, as you see for uh, TES.
Hmm.
It's progressive, and that really is the main differentiation for that one. And finally, unlikely if they don't meet the criteria for either, then it's strictly up to the clinician.
Yeah.
Um, I know
Hmm.
this was kind of complicated, but if you go through each line as we did, you can understand how the diagnosis is reached. And a fair number of people do meet the criteria. The most limiting factor is it progressive? Is it static? And do they display the symptoms in each one of those,
Categories.
boxes
Yeah.
or how it's, yeah.
Right.
Um, so I'm going to ask you based on what we discussed. I mean, I hit
Hmm.
I hit enough boxes for possible.
Yeah. I mean, I think I hit enough boxes for probable.
Probable. Yeah.
And I'm very interested now in getting a PET scanner, doing some,
Now,
whatever,
it's
getting
not
them the
necessary.
fluid checked. But
It's
oh
not
yeah,
necessary, that you get it for tests. You definitely meet the criteria for TES.
Right.
So do
Okay.
I. But as far as the CTE, that would, so, I mean, whether getting specifically that CTE diagnosis matters or whether TES is sufficient.
Right.
Um,
They're not, I wouldn't assume they're going to treat it any differently.
Unfortunately, there really isn't at this point much we could do. I mean, for
Yeah.
studies, and I suspect we're going to see the TES criteria overtake the CTE criteria over time, at least from clinical side. Um, it's a
And
difficult.
so you're thinking with more, the more data they get, the more research and brains that they can autopsy, that then at that point they'll be able to put those statistics together and say, okay, yeah, we know. I mean, this is showing
We are certain,
enough.
right,
We're
exactly,
showing, yeah,
that you won't have to rely on the PET so heavily, or they'll find something they could do with an MRI or fMRI that will allow them to say, yeah, we're like 90%. Because any of these conditions, even ones we've known about for decades, or have confirmed for decades, um, you can never say absolutely certain. You can only say it's likely or probable. Um, yeah.
yeah. When I first started doing research about CTE and found out that they had known about it since the 1920s, I just couldn't believe it.
Part of the problem is taking it seriously. Unfortunately, especially stuff that we really can't do much about. I mean, Alzheimer's is the same way, and PICS and some of these other diseases. Realistically, on traumatic brain injury in general, anyone who's watching, that what can we really do? I mean, we could do rehab for TBI, which is great, but
Right.
there really are no cures per se. We can treat the symptoms with medication therapy, but we really can't reverse it.
Yeah, a lot of these guys, back in the day, they were probably just written off. Their lifestyle, they were mostly boxers,
Yeah,
fighters most of their life, probably had a little bit of a rougher lifestyle, and then people just, probably wrote them off. They probably started drinking, and
yeah.
because there wasn't enough understanding, in the medical community about it, you know. So it makes you really wonder what the percentages really are, for a lot of these athletes,
And it's like,
or not only athletes, anyone in general with head trauma.
yeah, and the truth is, like those who suffered more severe traumatic brain injury, we had discussed this and we talked about it in some other situations. Most of us would have died anyway.
Oh,
Um,
right. Yeah.
those of us who would have been on ventilators, I mean, I needed a vent irregularly, but I needed one. Um, a mere like 60 years ago, it's like they didn't have those type of vents for the ICU or anything like that. I would not have survived. Um,
Yeah.
so, it's like they didn't do research. And this is part of why um, there really wasn't a lot invested in it anyway. You're right. A lot of the boxing types or the martial arts fighters types, and whatever you have back then, it's like, oh well, you died anyway. And many would have died of infections and other things. And unfortunately,
Right.
with domestic violence and stuff like that, again, we have a problem with you know most women are not believed, or it's like they may be, but it's like many survivors of DV, it's like though the police and judges are incredulous why they might go back, but if your brain is damaged, your judgment skills aren't as great as they should be, and you end up going right back into that kind of same situation. And those of us men who have been survivors of DV, it's like we end up, we're damaged the same way, and our judgment is impaired. And I don't know, men with disabilities have the same number, have the same percentage of us are likely to be abused at some point in our lives. Again,
Wow.
it's related to mental impairment and stuff. You and I have talked about this.
Yeah.
Um, and so, it's like, and if you're better off, if you're financially better off, and in your situation like that, there really isn't a place to go, which is kind of paradoxical, but it isn't. And if you're in the medical professions, it's the same thing. And
Yeah.
so, and a lot of them suffer traumatic brain injury from. So it's a very difficult thing. And then it's like you may get brain injuries. Just the number of people I've seen working when I'm working in the just daily with kids, like
Yeah.
downstairs, doing boy things, jumping off the back, off the roof, or like,
Right.
just screwing around.
Exactly. Yeah.
Forehead injuries, easy peasy lemon squeezy. That is not a hard
Right.
thing to come by.
Yeah.
I'm willing to bet the numbers are probably like 40 or 50% of the population is at risk. And I would love to know how many people in a nursing home really do have it. I would love to do an analysis like that.
Yeah.
I'm sure we'd be blown away if we knew how much. Maybe the problem is just too big to easily handle. I mean, I have considered, like thinking about it. It's like
Right.
maybe it's even more than 40%. Maybe it's more like 60 or 70%. And at that point, you start saying people get written off because they just form the vast majority. And they're like, oh, well, that's just part of living. And that kind of
Yep.
casual dismissal. But we can't do that. We need to invest a lot more in treating it then, if that's the case. But that thought has
Yeah.
occurred to me too. That it's just so big that it gets dismissed as the price of living. But we've
Right.
got to do better.
Or you
Right.
bring up retirement homes or whatnot,
Mhm.
and you think a lot of those people are probably at that age starting to really go crazy, senile. I mean, it's probably bad. And so for the family, I mean, for me, I don't know. I think it was a bit of peace when my family, when I had my brain scans, and it was like, oh wow, it was like, oh, Blake's not crazy. It's like, oh, now we kind of can figure out what's going on. We can manage this. We need, there's certain things you need to do, but I just can't imagine being written off that old and just kind of wasting away and realizing, it was just head trauma or CTE, and
Well, the thing is,
either it could have been avoided or the situation could have been handled completely differently.
these are all those like gray, I don't know areas, unfortunately. And honestly,
Yeah.
these all need to be explored. And this is the kind of questions that honestly keep me up at night, wondering like how many, and it's like, is it way more than we realize? I mean, if that's the case.
Yeah, you would believe how many people will reach out to me. And I hate to say it, but it's wives who reach out to me,
Mhm.
and either seen a video or post that I've made and just said, "Oh my gosh, my husband acts like you." And I'm like, "Okay, let's go over his history. What treatments is he on? Is he on any medications? And it's like, "Oh, please get him to a doctor." And a lot of them say they're so stubborn they won't even go to a doctor.
Right. Well,
And so you almost have to get ahead of it before you get to that point, because you start getting to that kind of point of no return. And it's like,
mhm.
man,
Well, hopefully some of what we've done here, I mean, obviously, it's like this, feel free to place this on your,
yeah,
on your site, please. And we will put this on detours, of course. And
yeah,
like, hopefully a launch point for some people to consider. Um, and just as a little going away reminder, here is a picture of a brain after, in very late stage CTE. A brain can lose up to 1 pound or 2.2 kilograms of its mass in late
wow,
stage CTE. That is fully 1/3 of its mass of brain tissue.
that's eye opening.
Yeah, 1/3 of its mass in brain tissue. It shows you how devastating TES CTE is. And this
Yeah,
is why, it's like it is intelligent to use careful judgment when letting your kids play, or like about getting out of dangerous situations and doing everything you can to protect yourself. All right.
right.
Well,
We should definitely like plug, don't like flag till 14. I mean, I don't support football at this point, but if you're gonna have your kids play, allow them to learn the basics, the skills, the speed, the
right, flag.
conditioning, the discipline. Play flag, and
Mhm.
allow them to have a chance. Right.
Right.
I mean, it lessens the odds so much just to protect them while they're young. And yeah, we got the Seattle Kraken. Yeah, I kind of wore this ironically today for our video. They're Seattle's hockey team. but you gotta
Yep.
love it. I mean, you love sports, but at the same
Yep.
time, it's so hard for me to watch anymore.
Yeah. Honestly, it's like, and it goes beyond, beyond the contact sports. It's just about every sport has this as a high risk. So it is, use your
Well,
judgment. Always, make sure you get an adequate assessment. We will be talking about basic ways to assess in the future, and I'll be discussing that, and
mhm.
things you could do. And please, if there's any doubt or questions, don't don't push them back in there. Don't get back on the horse. Don't go back into the football field. See your PCP. Go to the ED. Go to urgent care. Okay.
I do push the football a lot because it's not that I just think, oh, it's just football players, but I mean, there are a lot of
No,
them.
no, no.
But
But
I
that's
just
the one
think
that's
there's going
known.
to have to be a pathway. There's going to have to be someone
Right.
studying who's somebody, a group of people,
Right.
and it's
Mhm.
the best group to study to be able to implement those types of things for
I
everybody to
understand.
then, yeah.
It's like we know the circumstances and we can follow. Nope. Makes total sense. All right, everyone. We're going to be saying bye. And please click like, subscribe, follow Blake's channel, follow our channel. Please comments below. And please, any thoughts, questions, anything like that for either of us down below. And bye.
Have a good one.